Hey everyone, welcome to the simplest yet most powerful medicine and pharmacology learning space on YouTube. I'm Dr. Stephen, MBBS MD, and in this series, we're doing something refreshingly different. No face cams, no distractions, just clean, concise PowerPoint slides and an exam oriented voiceover you can trust. This is your postgraduate level clinical guide to insulin, a topic that's high yield, confusing, and yet totally conquerable. So if you want complex concepts simplified with a clinical edge, hit like, subscribe, and share this with your med buddies. Let's unlock the secrets of insulin starting now. So here's what we are covering today. From understanding diabetes mellitus to exploring insulin types, mechanisms, the clinical pearls, and bonus nuggets that are exam favorites but often missed. Let's start. What is diabetes mellitus? Diabetes mellitus is a chronic, progressive metabolic disease. It is characterized by persistent high blood sugar levels due to insulin deficiency or resistance or both. It affects carbohydrate, fat, and protein metabolism. Now, according to 2024 ADA guidelines, a person can be diagnosed with diabetes if they have a fasting glucose level of 126 mg per deciliter or higher, a 2-hour post OGTT glucose of 200 milligrams per deciliter or more, an HbA1c of at least 6.5%, and lastly, a random blood glucose over 200 milligram per deciliter along with symptoms. The complications can be microvascular like retinopathy, neuropathy, and nephropathy, and macrovascular like coronary artery disease or stroke. There is also chronic inflammation, oxidative stress, and damage to the blood vessel lining. Now let's start with types of diabetes mellitus. Type 1 diabetes, also called insulin-dependent diabetes, occurs when the body's own immune system destroys the insulin-producing beta cells in the pancreas. Most cases are autoimmune, called type 1A, while some are idiopathic, including rare viral causes like echovirus. These patients present with classical symptoms of hyperglycemia and may land up in diabetic ketoacidosis if untreated. Type 2 diabetes, the most common form, is characterized by the body's reduced sensitivity to insulin and impaired secretion. Although insulin is still produced, it is not enough to overcome the resistance. Chronic complications include damage to small and large blood vessels, leading to retinopathy, nephropathy, neuropathy, and heart disease. Type 3 diabetes refers to hyperglycemia secondary to other medical conditions or drugs like chronic pancreatitis or steroid use. Type 4 is a gestational diabetes which occurs in pregnancy due to insulin resistance from placental hormones. This needs prompt control to prevent fetal and maternal complications. Now let's look at the structure of the pancreas, particularly the islets of Langerhans, which are clusters of endocrine cells scattered throughout the pancreas. These islets contain four major cell types. Beta cells, making up around 70% and are the most abundant. They produce insulin, the key hormone for lowering blood glucose. Second, we have alpha cells, about 17%. They secrete glucagon, which raises blood glucose by promoting glycogen breakdown. Next, we have delta cells, around 7%, produce somatostatin, also known as growth hormone release inhibiting hormone. It regulates both insulin and glucagon secretion. And finally, we have the F cells or pancreatic polypeptide cells. They produce pancreatic polypeptide involved in digestive regulation. Now let's move on to the structure of insulin. Insulin is a 51 amino acid hormone composed of two chains, A and B, held together by disulfide bridges. In pancreatic beta cells, it's stored in the form of hexamers stabilized by zinc. On demand, it's secreted as active monomers into the blood. Now let's see how the journey of insulin production and secretion takes place. The insulin gene is first transcribed into mRNA, then it's translated into pre-proinsulin in the rough endoplasmic reticulum and processed into proinsulin. Next, in the Golgi apparatus, it's packaged and enzymatically cleaved into insulin and C-peptide. Both are secreted together into the bloodstream in equal amounts or equimolar amounts. Next, we'll see the control of insulin release from beta cells. So after a meal, glucose enters beta cells through GLUT2 transporters. Once inside, it's metabolized and ATP is released. This closes the potassium channels, causing depolarization. Now, depolarization opens calcium channels, which allows calcium ions to enter, which then triggers the fusion of insulin granules with the membrane. This releases insulin into the blood. This is a simplified diagram. Now let's move on to the mechanism of action. Insulin binds to a receptor called a tyrosine kinase receptor. This activates two main pathways. The first is the PI3K-AKT pathway, which causes GLUT4 transporters to move to the cell membrane. Glucose can then enter the cell. The second is the MAPK pathway, which affects gene expression and cell growth. So once glucose is inside, it is converted by enzymes into forms that the cell can use for energy or storage. Next we have insulin deficiency, organ-specific effects. When insulin is low or absent, the body goes into a catabolic state. Fats are broken down into free fatty acids. These are converted in the liver into ketones. This leads to diabetic ketoacidosis. Proteins are also broken down into amino acids, which increases urea production and causes a negative nitrogen balance. The liver begins producing more glucose and breaks down glycogen, and it is unable to store any. Now let's see the sources of insulin. Initially, insulin was extracted from animals like cows or pigs, with minor amino acid differences from human insulin. Today, we use recombinant DNA technology. How? Human proinsulin gene is inserted into bacteria or yeast. This is used for mass production of safe and identical insulin. Now on the other side, let's see the effects of administered insulin. When we give insulin, the body switches back to an anabolic state. In the liver, glucose production drops and storage as glycogen increases. In muscles, glucose uptake improves and both glycogen and protein synthesis increases. In fat tissue, insulin promotes fat formation and reduces fat breakdown. Overall, insulin restores balance and reduces catabolism. Now let's quickly see the history of insulin discovery and development. From the discovery of insulin in 1921 by Banting and Best to recombinant DNA synthesis in 1980s, insulin's journey has revolutionized diabetes care. Each step, from animal sources to modern analogues, has improved patient outcomes, safety, and ease of use. Next, types of insulin. We have regular human insulin and analog insulins. Rapid acting analogues include Lispro, Aspart, and Glulicine. Long acting insulins are Glargine and Detamir. Degludec is an ultra long acting insulin. There are also premixed insulins like 70 by 30 Lispro. Research is now exploring oral insulin and once weekly insulins like Icodec. Next we have insulin classification. This is the latest update. Insulins are classified based on how fast they start working and how long they last. Rapid acting insulins start within 15 minutes and last about 3 to 5 hours. Short acting insulin begins in 30 to 60 minutes. Intermediate types like the NPH start in about 2 hours and last up to 16 hours. Long-acting insulins like glargine have no peak and last around 24 hours. Lastly, ultra-long insulins like degludec can last more than 42 hours. Rapid-acting insulin analogues. They are created through recombinant DNA technology by modifying specific amino acids in human insulin. These changes increase electrostatic repulsion, preventing insulin from forming hexamers. As a result, monomers are quickly absorbed into the blood, producing a faster onset of action, ideal for managing blood glucose surges between meals or maintaining levels between meals. These analogues start working in 15 to 30 minutes, last about 3 to 4 hours, and are clear pH balanced solutions given subcutaneously. They can also be mixed with NPH insulin for combined basal and bolus control. Let's break down the molecular edits that give rise to rapid-acting insulin analogues. For insulin Lispro, the positions of proline at B28 and lysine at B29 are reversed. This simple swap enhances solubility and speeds up absorption. Insulin aspart replaces proline at B28 with aspartic acid, increasing negative charge and repulsion. Finally, insulin glulicine makes two changes. Asparagine at position B3 is replaced with lysine, and lysine at B29 is replaced with glutamic acid. So each tweak disrupts hexamer formation, making the insulin monomer immediately available for action post-injection. Now, rapid-acting insulin comparison. The three main rapid-acting analogues are Lispro, Aspart, and Glulicine. They differ slightly in their molecular changes. For example, in Lispro, in the beta chain, on the 28th position, proline is replaced by lysine. Similarly, for example, in Aspart, same on the beta 28th position, proline is replaced by aspartic acid. Now, they, like I said, they differ slightly in their molecular changes, but all start quickly, peak early, and are ideal for controlling blood sugar after the meals. Short acting insulin or regular insulin. Regular insulin like Humulin R is used before meals or during diabetic emergencies. It begins working in about an hour and lasts several hours. It's the only insulin used intravenously, especially in diabetic ketoacidosis. Intermediate acting insulin like NPH has a delayed onset and longer action, making it suitable as a basal insulin. It's mixed with protamine and zinc to delay absorption. It's cloudy and given subcutaneously. Long-acting insulin, like glargine, mimics basal insulin secretion. It's flat, peakless, and lasts almost 24 hours. That means once daily injections can keep blood sugars stable between meals and overnight. Ultra long acting insulin. Degludec is a breakthrough ultra long insulin. Structural tweaks allow it to form multi-hexamers under the skin, which slowly dissolve, offering stable control for over 42 hours. This is ideal for patients needing flexible dosing. This has the longest duration of action among all insulin. Next, we have long and ultra long insulin comparison. Intermediate insulin like NPH peaks after 6 to 10 hours. Glargine has a flat action curve with no real peak. Detemir binds to albumin and sometimes needs to be given twice a day. Degludec binds albumin as well as has the longest duration of over 42 hours. These insulins are ideal for providing steady background coverage. This graph, as we can see, shows the duration and intensity of various insulin types. Rapid-acting peaks fast but fades quickly, while long-acting types like degludec maintain steady blood levels for extended periods. Now, finally, we move on to the last type of insulin, that is inhaled insulin. They offer a needle-free option. Afreeza, approved in 2014, delivers ultra-fast-acting insulin using Technosphere technology. Although convenient for type 2 diabetes mellitus, it didn't replace injections due to cost and lung safety concerns. We also had Exubera insulin, which is now withdrawn from the market. Now, moving on to the final section of our topic, the clinical pearls. Degludec has the lowest risk of hypoglycemia and the longest duration. Glargine U300 is especially helpful in elderly patients. We have regular insulin, which is the only form that can be given intravenously. The basal bolus regimens mimic natural insulin patterns, and the split mix regimens are still used where resources are limited. Rapid acting insulin should always be given before meals. Insulin resistance is common in type 2 diabetes and metabolic syndrome. The Somogai effect is a rebound high after nighttime lows, while the dawn phenomena is early morning hyperglycemia without prior low sugar. Next, we have must know exam nuggets. The insulin receptor belongs to the tyrosine kinase family. GLUT4 transporters are insulin dependent and are present in muscles and fat. Insulin should be stored between 2 and 8 degrees Celsius and should not be frozen. Allergies are rare but can happen more with animal insulin. Repeated injections at the same site can cause lipodystrophy. Insulin analogues offer more stable glucose control. Glargine and Degludec are the only insulins suitable for once daily basal coverage. High insulin doses and skin changes like acanthosis nigricans may suggest insulin resistance. Insulin pumps and continuous glucose monitoring are very useful in type 1 diabetes. Now I have few exam nuggets that are add-ons which you absolutely can't miss. Weekly insulin like Icodec could revolutionize how we manage diabetes. Inhaled insulin exists but is expensive and can affect the lungs. Proinsulin is processed into insulin and C-peptide. Measuring C-peptide helps us distinguish between type 1 and type 2 diabetes. And most insulin is cleared by the liver and kidneys. So we reach the end. And that's a wrap. You just finished a high-yield, exam-oriented crash course on insulin. This format, slides plus simple narration, is perfect for those who want to study with focus. If you like this, please like, subscribe, and share this with your colleagues. More high-yield content is coming. So until next time, stay curious, stay sharp. Thank you.